All right, second installment of COVID Ops here. For those of you who tuned into the programming webinar last week, thank you and welcome back. For those of you who did not, thank you for jumping in on this one. Today, what I wanted to talk about was training around pain and injuries, which interestingly has kind of become my niche, so to speak, or at least what I've been predominantly working with for the last three or so years here. So I've gotten pretty proficient with this one, and I think this should be a good one today. So hopefully we can cover some good information and appeal to a little bit of a wider audience. But with that, the main focus today is don't focus on the problem, find the solution. That's really what it all boils down to. And I think as strength coaches, sometimes we feel like we're inadequate or underprepared to treat athletes with injuries just because of our upbringing and our tutelage. But I think what I've learned over the last couple of years is we're a little bit more prepared than we think. But with that, I am not a medical professional. This is not a medical presentation and should not be used as such. This should not be used to treat or diagnose any injuries. I'm not qualified to do so, so please don't take any of this as gospel. This is just some stuff that I've found success with, and I'm just a strength coach talking to strength coaches. So in the event that you are injured, or if you're a coach and you have athletes that are injured, please consult with physicians, rehabilitative staff, athletic training staff. Always make sure you're clearing things through them first. Touched on this a little bit in the presentation last week, but just to reiterate, I do work in somewhat of a unique circumstance. I have a lot of contact hours with my athletes, and they are inherently injured, but they also are working with a network. So this is not just success or lack thereof that I've found. This is I'm just a piece of the puzzle. So, but with that for today, really the main goal with this is to help understand how to navigate training without the impediment of pain, injuries, and kind of how to work around that, and then also to to sufficiently restore strength to the injured site. There are some shortcomings to conventional rehab, and there are some things that are kind of left off of the table, so we need to step in and do our part. But really, what this all starts with is the pain cycle, and this is a pretty common thing that most people understand. But pain is affects such a high percentage of the athletic population, such a high percentage of just the working force, and we're seeing now that there's a lot to the manifestation of pain and then how you treat it thereafter. But if we take a quick look at this here, we notice one of the first things that sets in is psychological stress. And I think that's something that cannot be ignored in this process. We have to consider the toll that it takes on people psychologically when they're injured. Obviously, pain being a byproduct here, but what pain leads to in this one here, and even this one here are really three big points of emphasis of mine. Subsequent muscular guarding from the onset of pain, and then that's restricting ranges of motion. Restricted ranges of motion is going to compromise strength and muscular size. And then collectively, we're just going to get decreased function. So really what it boils down to for us is we're just trying to work on these variables that we can and trying to improve the situation as best we can without breaching our scope of practice. So to kick off here, we have a couple of terms and definitions. These are really just the way that I look at it, but really classifying these three is the big starting point, right? We have discomfort, pain, and injury. Discomfort is something we should expect in training. It's fatigue based. Usually, it's indication that we're undertrained or we're ill prepared rather. But these are the things that we're going to work through in training, and not only that, but target them in training. Pain is some kind of a mechanical disruption that impacts movement. So we go into a squat, we get halfway into the squat, and low back sets off, and we're in obvious pain. That's something that we want to avoid in training. We don't want to reinforce or exacerbate any pain. Injury is something that we know ahead of time. It's diagnosable. It's tangible. With these, we're going to we're primarily going to follow the guidelines of the doctor, the physical therapist, the athletic training staff. In some cases, maybe the head strength coach or the director of the program. But these are the ones that we know about ahead of time, and we just have to have a good, thorough plan for before we dive in. Two things that we're going to kind of go back and forth on today. Conventional rehab, this is what we all know. With all the certified bodies, physical therapists, athletic trainers, so forth. And then really where we fall into play here is this term that I've, I guess, kind of coined here of restorative strength. So we're really using strength training as a means to further rehabilitate injured sites while putting an emphasis on restoring foundational strength levels. And that's, again, kind of what I've fallen into over the last few years here. So that's what we'll be breaking down as we go along here. From the jump, we want to try to classify movement limitations as either deficiencies or intolerances. A deficiency is something that's an incomplete movement, it's insufficient strength. Some examples being an end range hip flexion of about 80 degrees or incomplete upward rotation of the scapula. These are the items that we want to emphasize and directly address in training. Intolerances are more pain-induced symptoms, and it's usually set off by specific movement patterns. This can also depend on the position of the athlete, the stance that they're working from, and it can sometimes just be single-sided. But some examples on this being, a trunk flexion intolerance where, they get into that forward lean and then the low back starts to set off, or overhead flexion. Big toe extension is another one that's very common, where split stance work is really going to be off the table because that big toe extension is just going to preclude them from being able to do so. But these should be approached cautiously and not agitated in training. So we want to be able to differentiate between the two and understand how we need to go about those. But collectively, your goal is really to just be proficient in distinguishing these two. Much of this being identified in the assessment, which we'll get to in a second. But we want to address and progress the limitations as best we can, and obviously as safely as we can. Some common injuries that we have to work around. I guess these are specific to where I'm at right now, but some shoulder injuries, impingement, tendonitis, bursitis, slap and cuff tears. Non-specific low back pain is a big one in just about any community. In my world, disc injuries are a big thing. Surgeries are a big thing. At the hips, impingement, FAI, labrum tears, arthritis. Knees, these are actually probably the least common that I see. But I know knee injuries in the sport world are obviously big. But tendonitis, bursitis, ligament tears, arthritis, cartilage. Excuse me. Down at the ankle and the foot. Achilles tendinopathies and ruptures, chronic sprains, plantar, toe injuries, and then, again, one that may not be particularly common outside of sport in their tactical world, but, vestibular impairments, motor control, and disrupted neuromuscular patterns stemming from head and cognitive injuries. One thing to consider is that there are a lot of different tissues at play here. There are a lot of different systems at play, and all of these are always working. They're always involved in what we're doing, or they should always be considerations. And really the big thing to know is what do they respond best to, and what are they aggravated by? So if we look at tendons, the best way to get a tendon response is to load it heavy. That's not always feasible, and that's not always, capable at times, but we want to try to put tendons under load as early and as best as we can. Tendons are mostly going to be aggravated by the speed of contraction. So even when athletes are coming off of a tendinous injury, sometimes they can load it heavy. They just can't move it fast. Ligaments respond best to full range of motion. We want to try to improve the structure of the joint by putting it through a full range that it's capable of moving through. We want to use a progressive load tolerance here. And also another thing to consider with the ligaments is resisting torque and shearing forces. If we think about an ACL mechanism, we're thinking a combination of femoral internal rotation and tibial external rotation with forward translation of the tibia. So, it's a multiplanar thing a lot of the times too. Muscles, probably the one we know best, but respond best to load, full range. They also respond well to speed, but muscles are going to be aggravated by excessive loading, and this can be a position-specific thing. Bones, Wolf's Law, respond best to load. We want to load bones. And when we're coming off of a bone injury, we just want to be mindful of aggravating it through excessive force impact. Nerves, fascia, a little bit less known, less understood. I'd say at least by the strength coach community, but for nerves, we're looking at speed, complexity, challenge. Nervous system is always a part of what we're doing, but if we really want to target, so to speak, the nervous system, we're going to think speed, complexity. Really, nerves are aggravated by overload or system shock. So, what can you tolerate? There's an obvious threshold, and we just want to make sure that we don't breach that threshold early, and then in the long term try to improve where that threshold sits. Fascia is going to respond best to force and dynamics. So just thinking ballistic plyometric type movement and higher force outputs. Fascia can be aggravated by a litany of factors, but one that we're going to talk about a lot today is really just health and wellness. But we want to think movement, flow, and continuity when we're talking about fascia. Not going to spend too much time on this one, but some hormonal responses to exercise. We look at really what the target tissue is: skeletal muscle, skeletal muscle, skeletal muscle, all the way through here. So really that's just, in my opinion, a way of kind of validating the importance of loading tissues and loading the athletes, even when they're injured, even when it's seems to be early in their injury phase. We want to create a lot of these hormonal responses to help give the body what it needs to return back to full health, and to restore the injured sites. And we look down here at IGF-1, almost all cells, right? So IGF-1 is one that is extremely important in early phase rehab. So we just want to keep these things in mind and understand that there's a lot going on at all times here. So some factors contributing to pain and injury here. Different structures give athletes unique advantages, but they also come with a cost. And really, one thing that we've kind of gone back and forth on for a while now is that term injury prone. Is injury prone really a thing? Well, yeah, kind of. I just think that we use that as a negative term to kind of either excuse somebody from not reaching their full potential or underperforming. But in all reality, injury prone is a combination of these factors here, and you can certainly have influence on this, but I think there are some of them that are just going to be what they're going to be. We look at basic anthropometrics and genetics. A 7-foot power forward or center in basketball is going to be at a little bit of a different injury risk just based on the fact of how long their limbs are. It's really not any more complicated than that. But on a more common scale, we want to look at the limb length and then the ratios between the limbs and the torso, and the upper and lower leg and the upper and lower arm. These things matter. But in addition to that, bone densities, the site of the tendon insertion, the fluidity of the nervous system, all of these things are going to play a factor in somebody's propensity for being injured. General exposure to risk and physical demand. In my world, with the tactical community, there's nothing in the world that we can do to prevent them from, sustaining some of the injuries that they're going to sustain. It's impossible. It's just a part of their work. But, we want to consider how much of a risk they're at and what those factors are. General health and wellness, we're going to talk a lot about this today, as I mentioned, but it's hard to bulletproof an athlete when you eat and sleep like shit. If you're not eating right, if you're not sleeping right, if your stress management is out of control, we're really going to be working backwards. Strength ratio and balance. This is, kind of, we think back into, kind of the olden days when, every athlete in the world was proficient on bench press, but, you wouldn't catch anybody dead squatting. So, strength is great, but how is it distributed and what does it look like in action? To quote the great Deion Sanders here, look good, feel good, play good, right? Tissue quality is extremely important, and I think there's also a psychological side to this. But on a tangible scale, we got to be able to move, and we got to be able to move well and move when we need to. But what it all boils down to here is there's countless variables. We can list out millions of different things that can be contributing to pain and injury, but what we want to focus on is what we can control. So we look at this really cool, complex graph here that makes me look a lot smarter than I am. But I did not I did not throw this together. But what we're looking at here is really reflex inhibition and the responses of a joint injury. So if we look at joint injuries, we're obviously thinking about tendons and ligaments. Reflex inhibition would actually denote tendons specifically here, but a couple of things that stick out. Number one is altered muscular function. So we have a joint injury, we're going to get altered muscular function. When we have altered muscular function, we're likely to have increased adipose tissue. Adipose tissue being fat retention. Part of that is mostly due to just inactivity and immobilization of the area. But we look down here, potentially a shift in slow twitch and fast twitch fibers, and that leading to increased muscular fatigue or fatigability. So altered muscular function, more fat in the area, less trained or less capable of resisting fatigue. Then we have compromised tissue dynamics and force generation. So now we're impacting performance directly. This creates muscular unloading, and then we're back around to fat infiltration and muscular atrophy. So, again, with all of these, with these charts and graphs, the point being just seeing how many different responses or how many different variables there are from, something just as simple as a joint injury. And honestly, this is a pretty basic overview here. So can we predict injury? No, of course we can't. We can do what we can do, and I think what I've looked at here recently is breaking it up between predictors and then semi-predictors, right? And I'm sure my physiotherapist crowd and my sports scientist crowd is going to love me for saying this, but the only things that can truly predict injury are previous injury and what are they exposed to, right? And that's really it. But if we look at semi-predictors, we can get into resting and dynamic postures, tissue quality, active and passive ranges of motion, intolerances versus deficiencies. These are the ones that I really try to emphasize, but there are several more we can put on here. I think if we look at a host of variables, when an athlete walks into our facility, we can get a pretty good idea of, what their semi-injury risk looks like, and what we can do to influence that. So don't take this to heart here, but I think it's a little bit neglectful of us to say that, oh, well, there's nothing we can do about injury. We have no control over it whatsoever. Well, an athlete who trains hard compared to an athlete who doesn't train hard and does all these different recovery modalities, they're going to be at a less likelihood to sustain injury. I mean, I think that's kind of common sense. But yeah, taking it, right in stride here, there's nothing in the world that says we can definitively prevent injury, but there's a lot of stuff that we can do to reduce the likelihood, and I think that's a fair compromise. So some preliminary considerations here. Big picture, so 10,000 foot view here. If it causes pain, we got to stay off of it. Remember our rule of thumb, our golden rule is first do no harm. So if our goal is to get the athletes out of pain, why would we push through those movements or those sets that are inducing pain? We got to stick to our goal here and know when to cut it short when we need to, and have control over our session. But at the same time, it's important we don't confuse pain with discomfort. Discomfort is something that we should experience in training and that we should, kind of expect to see or sustain. When we're looking at the timeline here, early phase rehab, 0 to 6 weeks, this is still very much a, even a doctor oversight for some injuries, but physical therapist, athletic training staff, they're going to be in charge here. Physical therapies and athletic training staff as well will be, taking the lead at least, weeks 2 through 10. And then where we fall into place here is beyond 10 weeks. But I think an important thing to consider with this is, how much of how much is missing from conventional, therapy and rehab methods that really we can address and emphasize as strength coaches. Um, and all the while we want to consider the theoretical norms. Don't live by them, but it's important to at least have an idea of where the athletes are compared to where they theoretically should be. And some other things, we want to make sure we monitor daily pain levels. I think subjective pain is perfectly fine because, again, if the athlete is telling us that they feel good or they don't feel good, I think it's important that we kind of lead with that, in lieu of anything else. Um, you got to know your boundaries, got to know your scope, and really, when you're working with injured athletes, you must know your anatomy. Before I started working with injured athletes, uh, honestly, I wasn't too adept with my anatomy at the time, and you can make your way with athletes that aren't injured and still have an effective outcome if you're not super proficient with your anatomy. But when we start talking about injuries, you got to know. And lastly, keep the athlete's goal in mind. We're working towards something all the time. When athletes have been sidelined or they've been pulled out from competition or duty, they can get distracted and dejected pretty easily. So we want to keep micro progressions and short-term goals in sight here. So some of the variables here, general wellness, aerobic base. I think this is a big one, and I think it really, really gets ignored a lot. But we want to, make sure that we're giving the athlete every advantage that they need to succeed. And I think a big one is starting with a general wellness and aerobic base. Sleep hygiene, nutrition panel, medications, pain management, and developing our professional network and looking at external modalities. A lot of the times, this is a holistic process that we can't treat independently. For our aerobic base, I just use the Mike Boyle rule. Anything below 60 beats per minute, you're probably in good aerobic health. For resting heart rate, that is. Anything above 60 beats per minute, we probably need to look to get in a little bit better shape. Heart rate return, heart rate variability. These are things that are going to influence the capacity of training. If we can't control heart rate, if we can't get back down to a good heart rate to work from in between sets, it's just going to compromise our ability to train hard. Blood pressure, we consider the Valsalva if we have guys or girls in here with high blood pressure and or untreated or undiagnosed blood pressure issues. Putting them under conditions where the Valsalva maneuver is going to be present could be problematic. So we want to be aware of these things. Stroke volume, work capacity, again, just being able to do more and do more better in training. A lot of these are really relying on these cardiac measures and these aerobic measures. High level athlete does not equate to a high level health. I think this is something that's easily misconstrued. We look at elite athletes and we assume that they're just, probably stellar across the board. That is absolutely not the case. So never assume that. Things like relationship, marital stress, stress management, social wellness, alcohol and narcotic use, all of these things are going to be influencers for our ability to train and then recover thereafter. So another cool little chart here. This one looking at disruption to circadian rhythm. And again, we're not going to go all the way through this, but really the two that I wanted to look at here, we see increased inflammatory cytokines and reduced neurogenesis. So really this one meaning, the ability for nerves to repair after they've been damaged. So if we have disruption to the circadian rhythm, then we are going to actually, have a harder time recovering from training. And really the main takeaway is just lacking fundamental homeostasis can be a major impediment to training and training return, and really that just kind of boils down to working harder for less result. For sleep hygiene, we're thinking about 7 hours a night is our empirical number here. Prolonged less than 7 can be detrimental to health and detrimental to training for sure. Monitoring blue light exposure, especially if we're working with college athletes, high school athletes, making sure that they're not staying up on Twitter and TikTok and whatever the hell else now, late at night. All of these things that really just boil down to, REM sleep and trying to preserve REM sleep as best we can. And establishing a consistent routine is step one. We always try to look to the more immediate solutions and quick fixes, but, do you have a routine developed? Nutrition panel, again, don't assume high level athletes are healthy and well. We can't out train a bad diet. If they eat like shit, they're going to train like shit. Sometimes there are exceptions to that when athletes are younger and I guess accustomed to eating poorly. But, does the intake meet the demand? If we're training hard, we got to eat right. Hydration should be, pretty straightforward for all y'all. But, we're thinking about 1 liter to 1.5 liters a day, and we want to emphasize micronutrient circulation and tissue quality with the hydration. Sleep deprivation, tons and tons and tons of material that we can get into on this, but very simply here, increased heart rate variability, so we have less control over heart rate function, and increased reaction time, decreased accuracy, irritability. We can go all through the list here, but when we have athletes who are under sleep deprivation, they're absolute considerations for training, and like right off the gate, just removing power work, plyos, sprints. When the athlete is sleep deprived, the nervous system is not functioning correctly, so we got to be mindful of those heavy neural dominant exercises or modalities. Usually we want to extend the warm up for this crowd and know that they're going to have probably a little bit of a delayed recovery and a little bit of an increased susceptibility to injury and illness. So, these are things to be aware of. And again, in my world, it's quite a common thing. When people are in pain or injured, they're going to be on medications. So, the effects of these are wide reaching, and really these are just looking at heart rate and blood pressure. But, we got to think beyond that too, and how it affects cognition and motivation and vigor and drive and, general mood, So there are a lot of different things to consider with this, but I think what's important is knowing, what are the contraindicating medications that they're taking that you need to be aware of, even things like alcohol, caffeine, nicotine, because again, depending on dose and tolerance, those can have more of an effect on training as well. But looking at your common ones, your antidepressants, vasodilators, beta agonists, beta blockers, calcium channel blockers, ACE inhibitors, just know what those ramifications are. Then we look at external modalities. Again, I'm in a unique situation where I'm always working with a network of people, and it's really made my job so much easier. And I think one of the big things with that is understanding what you can learn from other modalities, and seeing the same things from a different perspective. A lot of the times, it's really changed my approach. Just hearing the way that a massage therapist describes, a torn hamstring muscle, versus how an athletic trainer may look at it, and just getting a different perspective sometimes can be very helpful. But, know that you're not alone. You don't need to fight this battle alone. And if there's a demand for it, always reach out and refer out and utilize those people that you can. So now ground zero for us. So now here we're looking more at the tangible sides of all of this and the training side. I've talked a lot about this, but restorative strength, I've really latched onto this term because I guess to me it just really makes sense. But really the goal here is addressing or improving the areas of weakness and deficiencies without compromising the strengths or performance. So we're working a delicate balance here, but really the goals are simple. There are injuries or there are weaknesses that need to be addressed, but we can't preclude or limit the performance side of things or the strengths while we address these. So, it's important that we take the time to understand, where somebody is, what they need from us, and what their timeline looks like ahead. But with that, some of the things that are very common with this restorative strength modality is, utilizing band accommodations, Again, another one that I've talked about previously, but using bands to unload or assist or feed movement patterns. Taking a quick look here, we utilize a band here for a split squat for somebody who may not be able to get into a split squat at body weight. The band is going to reduce the mass. Same thing here with a goblet squat, right? The band is unloading the squat as we get into it. So this can help people to get into deeper ranges of flexion that they may not be able to, naturally or on their own. And then again here with a Messier rock, just working a frontal plane or a lateral movement here. But again, the concept with the bands being that, we need to find what that external load is for them that they need and what they're capable of doing. We also look at foot position, hand position. These are things that we can adjust on the fly that a lot of times can have, big outcomes for us and, finding that sweet spot, so to speak, for some people. And then we want to work basic to complex, thinking in layers and building robustness and durability, thinking in resiliency. I know I bludgeon you all over the head with this every time, but really can't emphasize enough. The assessment is so critical for so many different reasons, but as it applies here, they're going to give you the answers to the test. So whatever your assessment protocol looks like, make sure it's holistic and it's looking at from some different lenses, but they're going to tell you what they need. So sport specificity, very simply, is the demands of sport plus the weaknesses and deficiencies that they show you. Really, that's all it boils down to. What do they need to do? What do they show you they need? That's what we're going to put in play. The athlete will tell you what they need. So we're going to look at our deficiencies versus our intolerances, attack what's weak, avoid what's injured, start with general, work to specific, start with basic, work to complex. Some common items for me here. So almost everybody that I work with has some kind of a shoulder injury, whether it's a slap or a bicep or a cuff. But the whole point of this, and we don't need to go line by line on here, the whole point of this is, isolating exactly what we found in the assessment and then specifically putting together some points to approach these or to improve them, right? And we go in a hierarchical fashion where we want to put the emphasis on what they came in primarily complaining about or citing as their issues. So, for instance, we have somebody come in with a slap tear, but they also have, a poor resting and working posture. We want to make sure we address the slap directly and initially, but also get around to working on improving gait and postures. And the irony there is that, this is going to help this is going to help this. So it's all important. We just have to understand the level of importance, at least initially. And a couple, kind of a similar slide here, arm drop and shoulder, elevation of right side of rib cage, just kind of some of the more micro details here, but we want to make sure that we are putting a plan together for what we're seeing in our assessments. Some of the things that, are pretty common for me, and I would imagine, for others as well, when we're working with injured athletes, is single leg work, single arm work. We're going to get into a couple others here, but I've taken a lot of attention off of bilateral movement when I'm working with injured athletes. Really, the primary goal is to get each side working for itself independently, but I think it's important to understand that there's no inherent good or bad exercise or something that we have to do or can't do. So we'll dive into a couple of these here, but starting out with single leg work, really what we're getting out of this is triplanar stability. So we know the hip is a ball and socket joint, and we know that we should be able to have uh, movement in multiple degrees of motion in multiple planes um, at the hip. So I think it's important with single leg work to approach from different angles. So we'll kind of clip through here, but a simple one that Nicole's showing here, dumbbell single leg RDL. Not only are we getting a good hamstring work, eliciting a good hamstring stretch here, but we're also resisting falling over left to right. So that triplanar stability is perfectly demonstrated here, where we're getting the hip to stabilize in multiple directions. Actually, here's a really good one. You see the leg shaking as she's going into the step downs, right? So we're not just loading quad and ham and glute on this leg, but we're also resisting falling left and right. And when we're looking at athletes who are coming off of injury, this is a really important concept for them. So, yeah, a couple more here, but working in different directions, working different movements, contrasting patterns, all fair game here. Improved socket congruency is another big part of that. So getting the hip to be a hip again, and letting that thing, the labrum especially, kind of improve its strength. The hips are work bilaterally, but they also work independently and unilaterally. So with single leg work, we're obviously forcing that, and I think for the SI joint especially, it's appreciated. Another benefit to single leg work here is improved foot strength, which is another big one that will have sweeping ramifications. Single arm work, kind of along the same lines, allowing the joint to work for itself, increased demand for the core and the pillar, bracing stability and mechanics. But the big one with single arm work that I'm always interested in is it's highly beneficial for the rib cage. I think a lot of the times, especially when athletes are coming off of shoulder injuries, the rib cage really gets banged up and doesn't get a lot of love after the fact. And if we get somebody's rib cage to start moving again, and not only just expansion and depression, but also being able to work a little bit unilaterally or ipsilaterally and getting some rotation at the rib cage can really help the shoulders as well. We also think about the scapular glide across the rib cage or along the rib cage. That's another one that needs to be addressed in training. Contralateral work, so we're thinking, left, right, or opposites. Big one here is increased demand for motor control. This is a big brain one, but also high demand for the slings. Wherever we're working the slings, we're going to improve or think about lumbopelvic stability, and then also lumbar thoracic stability as well. And the demand for proprioception and coordination. So some of the basics on these, step ups, single leg RDL again, working into an overhead press. So if we think about that fascial pattern here, we're getting hip extension, overhead flexion, fascial front line here across, resisting that lateral torque, single arm Pavlov press. So again, not only are we working resisting lateral flexion here, but we're also resisting torsional rotation there. This one being a little bit more of a complex one, but glute bridge with a contralateral band pull. So again, we're thinking right lat, left glute, working that posterior sling. Oscillatory work. So this is something that I've just been doing more and more of as of late, and I got to say, man, with the injured population, this stuff really seems to help. I know that there's a very limited amount of research, if any at all. But when we're thinking about oscillatory, we're thinking like the water bucket overhead carry, the dynamic Pavlov press here. I know it looks gimmicky, man. I really do, and I know that this isn't something that's feasible for everybody to set up in their gym or with their athletes. But I think about the nervous system or human motor control as a river, right? Where the width of the river is our resistance to variability. right, or ability to tolerate variance. The depth of the river is our ability to resist fatigue, and the speed of the current is our speed of contraction. So with this, the perturbation and the oscillatory work, I think we're kind of hitting all of those. You saw the cuff carry or the plate carry with the band pull apart. We're getting scapular action on that, but we're doing it through a locomotive pattern. And I think that there's more to the motor control side of that than anything else. So again, I know some of these look a little goofy, but there's definitely prudence to these as far as I'm concerned. And then, my favorite, offset work. Again, we're thinking increased neuromuscular demand. With offset work, I really think about it as, you're only as strong as your weakest link. And when I first started messing around with offset work, I was almost confused, like, why is this so much different or so much more difficult? If I just have 10 pounds on the bar and I can overhead press, whatever, over 200 pounds, I have 45, 55 pounds on here, and it feels more challenging. It's shout out to Vern here for his guest appearance. But we look at offset work and we're thinking about finding the weak links in the chain, right? So this is, I'm not faking on this. These are tougher than they look, but we're getting a lot of good return here for core stability. Then we look at it with a band, an offset band push-up. Again, somebody can bust out 50 push-ups, no problem. You throw a band around them, and all of a sudden it might change the game a little bit. So we're definitely getting multiplanar stimulus. I think there's an increased cognitive demand here as well, but I can't encourage that enough. So now we get into modifying movements here. The first step is as simple as could be. Remove what doesn't fit. You don't have to bench press. You don't have to back squat. You don't have to deadlift. Those are great movements if you're capable of doing them, but whether it's a temporary or a permanent thing, remove what doesn't fit. There's no harm in that. Path of motion first, range of motion second. We can use the squat as the easy example, but if your squat looks like shit and you're trying to, get ass to grass type depth, you're really digging yourself a hole. I think, you're better off cutting the range of motion short, owning that range of motion, and then building it from there. Create stability before you find it is another big one. The body's gonna make it happen. It will find a way. We want the right way. So, proper bracing mechanics, proper breathing mechanics, these things all play a factor when we're trying to, train around injury. Create boundaries and barriers where you need them. If you have somebody who can't do a single leg RDL, have them do it with a hand support. You have somebody who can't back squat, which was me for a while with my, adductor groin injury or whatever was going on. I could not put 225 on a back squat bar and squat past, 50 degrees even without pretty significant pain, but I could load up 500 on a Hatfield, no problem. So points of contact and stability is a big one. But the overall point being give them what they need. And it's okay to be crafty with this. It's okay to explore some different things here. Won't go through these line by line, but looking at some ways to modify, or reasons and ways to modify the back squat. So if we look at common injuries precluding athletes, axial compression for spinal injuries, can't externally rotate, hip intolerance, whether it's flexion oriented or otherwise, are they coming off of a knee injury, ACL or meniscus, there's going to be a difference in protocol there. Inability to dorsiflex or stabilize the foot is another one that really, gives people some trouble with the squat. So some simple adjustments we can make is, just changing the bar position. So we can go from a front squat to a back squat to front, high bar to low bar. No success there, then we switch the implement. So going from a standard barbell to a safety bar, even taking it to a dumbbell goblet squat or a belt squat, changing your stance, wide versus narrow, split versus bilateral, box squat, again, Hatfield or band assist, modifying the range of motion so we can elevate the heels to help limitations at the ankle, or we can use a box to help limitations at the hip. We can, create a gradient path of motion. the changes or adjustments you can make are quite broad. So finding what they need and helping them find that solution is really what it boils down to for you. So um, some of the things that I've noticed, if you have major back injury history or surgery history, I just don't think back squats are a good option for you. You can sit here and tell me that you can do them without pain, and that's cool. Go for it. But I think you're going to be running some long term consequences with it. Most shoulder injuries can be cleaned up by just switching from a standard barbell to a Hatfield or a cambered bar. Um, Hip injuries can be difficult and highly variable. I mentioned a second ago with my own injury, that deep flexion for me just was not working. So I had to go to a box. I had to go to a Hatfield bar, and it definitely made some improvement for me. For ACL injuries, we want to avoid those quarter range squats. ACL injuries, we're thinking like 10 to 40 degrees of knee and hip flexion. So for ACL injuries, the top part of the squat is going to be the problem. For meniscus, it's the opposite. It's deep ranges of flexion that are going to trigger the meniscus or cartilage injury. So, knowing the difference on those is important. And then dorsiflexion can have sweeping effects. So we can start with a heel lift, but that's not always going to work. So sometimes ankles can be a real bitch to work through. When we look at modifying the squat, increase trunk flexion. You play with trunk flexion and you're going to get a much different effect. This also kind of goes hand in hand with like high bar versus low bar squatting. But if we increase trunk flexion, we're going to get an increased demand on the erectors and the flexors, but we'll reduce the demand for the knee. So if we have knee injury population, increasing the trunk flexion may be a step one for you. A more upright torso, kind of in the opposite direction here, is going to increase knee flexion, but spares the lumbar and the hips. So again, somebody with a low back or a hip injury that is still eligible to squat, try working from a more upright torso. We can go into a sumo position, right? Wider foot stance, kind of externally rotate the feet out. This is going to reduce the demand for hip internal rotators, predominantly because we're going to be in less degrees of hip flexion, but this is also going to spare knee flexors as well. So with that, the trade-off being it's going to be an increased demand for the quads. We're going to get an increased demand for the glutes. And then if we, play with the rotation, we can increase the external rotation of the foot, which is going to decrease somewhat demand of dorsiflexion. But the caveat on these is this is a coach's eye type of thing because we can make all of these different adjustments and still have people in bad positions. So make sure that you are queuing these up correctly. We look at modifying the bench press, spinal injury. Anybody who's going to be intolerant to lumbar extension, we want to prop their feet up on the bench, and if that's still a no-go, then we might just not want to have them in the prone position, or I'm sorry, the supine position. For shoulder injuries, obviously it's going to be the major limiter for bench press. Slap tears, we get excessive internal or humeral extension and anterior glide, we're going to have problems. We get that anterior glide of the humerus, and it's going to be pretty sharp pain for most slap tear populations. Cuff tears, we're going to think limited external rotation and watch for over-dominant traps. Something I've noticed with cuff guys is they tend to guard the scaps with the traps and kind of pull up. We want to think more space between shoulders and ears when we're pressing. Elbows, wrists, and hands, man, can these be tricky. I'm certainly not a specialist on this, but elbows, wrists, and hands can get tricky. Changing the hand position is our first step, going wider or narrower on the grip. If we don't get what we want there, we can change the implement. So we can go to a Swiss bar or a football bar. We can just go straight to dumbbells. Changing the stance of the setup, using a floor press to help with shearing stress at the shoulder, reducing shearing stress at the shoulder, because we have a pause in the change of direction at the bottom can be helpful for some. For others, it's more of the Thompson fat pad approach, or I'm sure most of you are familiar with Donnie Thompson. I was amazed to see how much this cleaned up for myself, actually, just having a wider base to press from. And then we can unload it with a band as always. Last simple adjustment is modifying the range of motion. So doing like a block style setup where we don't let those elbows get past, midline of the rib cage, is sometimes a helpful tool. Some things I've noticed, elevating the feet alleviates most for spinal, especially that lumbar area. Most, but not all slap and cuff tears, I'm probably going to stay away from a barbell bench and default more to dumbbells or a landmine press or, just kind of an adjusted or modified press setup. Bench press is a good option to prevent excessive, block bench, I'm sorry, is a good option to prevent that excessive humeral glide that I was mentioning, and hyperextension because the elbows aren't going to get too deep. And I think a big thing kind of overall here is utilizing your lats for pressing actions. When I bench press, I don't ever get sore in my pecs or delts or triceps. It's always in my lats, and we want to try to utilize those as much as we can on presses. For the deadlift, some common injuries here, spinal and injury. These are going to be very similar to the back squat, but for pulls especially, intolerant to lumbar flexion or thoracic injuries are going to be problematic. Groin adductor tears, glute tears, quad injuries, ham injuries. Those are obviously going to be limiters for deadlifting. Knee injuries, ligamentous, patellar tendinopathy, cartilage decrements. Those are all going to be problematic as well, but simplest adjustment on the deadlift is to elevate the surface, right? So we're going to pull from a shorter range of motion, give them a better opportunity to succeed. Changing the implement, so I almost exclusively use hex bar deadlifts to begin with, but if you're somebody who's a straight bar deadlifter, try switching to a hex bar, seeing if that helps clean it up. Usually that puts people in a more favorable position, and also because the load is suspended, circular, what's the word I'm looking for? Encircled around the athlete rather than a single fixed point like a straight bar. A lot of the times hex bar can clean up just off of that alone. Then changing our stance or our setup, so a wider versus narrow grip, modifying the torso position, modifying the hand position if we're still using a straight bar. Those things can help as well. What I've noticed, again, if you have a major spinal injury history or surgical history, barbell deadlift from the floor is probably going to be no dice. We want to elevate the surface for almost everybody. And again, just ask yourself, who is required to pull a barbell from the floor? If you're not a power lifter, or if you're not an Olympic weightlifter, then that answer is nobody. So, don't be fooled into that. We can get similar effects just by reducing range of motion. Similarly here, like we looked at with the back squat, playing with trunk flexion can have a big difference for a lot of athletes, and we're going to change what's being activated around the hip and the low back just by changing whether we have increased trunk flexion or a more upright torso. Similarly with foot position, right? We reduce demand for hip internal rotation and knee flexion with a wider foot position, but we increase the demand for the quads and the glutes. Same thing here down with the rotation. So playing with the stance and playing with the setup is a major factor for a lot of people, and I think those are things that get overlooked when we're thinking about these main lifts or primary lifts. So what do we notice with all this? There's always a solution. How far do we want to go down that rabbit hole of finding a solution? I think that depends on where the athlete is, what their timeline looks like, and how extensive their injuries are. But we can find a solution. So again, changing stance, position, changing the implement, path of motion first, range of motion second, using bands as we need them to assist or unload movement or feed a pattern, and creating barriers where they need to be created. These are all steps that we can consider to modify the movement so that we can move pain-free and still get a positive effect from it. Coming down the stretch here, some strategies for tangible improvement. We want to address the items of concern, and then from there think proximal to distal. But this is something that Sue Falsone actually really hammered home for me, because I started getting into a lot of the the different modalities of fascial release and soft tissue work and whatnot. But if somebody comes to you with an elbow issue, address the elbow. Don't do fascial release on behind their ears and then tell them it's going to help their elbow. Think about things from their perspective too. But proximal to distal, that's a pretty conventional thought. We always want to work in to out. Midline of the body is where most of the important shit is, and then work your way away from it. Similarly here, train above and below. We want to consider the relationship between joints, the elbow and the shoulder, the knee and the ankle, and then also consider the agonist-antagonist relationships. Active versus passive ROM. I've talked a lot about this, but don't seek to increase the total range of motion. Work to close the difference between the two. We'll get into these here in a minute, but working through gradient progressions of isolated independent strength, global integrated strength, and then adding layers to movement and kind of a cyclical process there in itself. And then we want to kind of collectively work to eliminate non-functional asymmetries and gross compensatory patterns. So, big thing with the proximal to distal thought is, is paralysis by analysis. We don't want to chase pain and try to, treat every little symptom that may appear. We want to try to find the root cause and then work from there. Above and below, Sherrington's law of reciprocal inhibition. So if I fire my quadriceps, my hamstrings have to relax. That's great in theory, but that's not always so simple, and it's not always the case. So we want to try to see, how the athlete responds to certain things and, where they're feeling certain movements. And a lot of the times it'll be different than what you would expect. So just understanding how each individual responds to things. And then we, along similar lines, look at lock long versus lock short, or tight versus weak. And this can be a whole presentation in and of itself, so I won't get too far into this, but strengthen what needs to be strengthened, stretch what needs to be stretched. So if we use a shoulder example, considering the tension of the anterior neck muscles and the effect that has on the collarbone position, that's going to change the whole mechanics of the shoulder. It's going to change scapular-humeral action. It's going to change their ability to get in degrees of overhead flexion. So we can do all that we want to improve the shoulder joint, but if we have excessive tension of the anterior neck muscles, what we're doing for the shoulder is null and void almost. So, make sure that we're addressing these things chronologically. Laxity of the elbow. The elbow and the shoulder are obviously inextricably linked, but elbow position will oftentimes be limited by shoulder position, and then vice versa. So I've had a lot of athletes who can't fully extend their elbows, and it creates an impairment at the shoulder. So another one where we can do everything in the world for the shoulder, but if the elbow isn't right, it's not going to work. The goal with passive to active versus passive range of motion is, again, it's not to increase the total range of motion. Some athletes don't need more range of motion, even if they don't meet theoretical norms. But the way that they're structured and the way that they're able to conduct or execute movement is what it is. So if we increase their range of motion, it actually may compromise that. What we want to do is try to close the gap between the two. So a smaller gap between active and passive range of motion is less likely to sustain injury, at least according to my logic. Once the gap is narrowed, then we can work to increase the total range of motion. So if we look at a hip internal rotation of 15 degrees on the right passively and only 5 degrees actively versus the left side where at 20 and 15, we want to work to try to treat this one right here. Get this 5 degrees up to try to be closer to 15. Once we get that, then we look to increase total ROM on both sides. Isolated and independent strength. So when we're coming off of injury, we want to make sure we independently strengthen what is weak. If we just, if we take a shoulder example again and we throw them right into, overhead pressing, bench pressing, and things that are all global strength applications, then we're going to kind of miss the point here, because what is strong is going to work when what is weak isn't. So if we have strength in certain muscles and weakness in others, we're going to reinforce strength in what is already strong, and we're going to continue to negate what is already weak. Once we establish the independent strength, then we want to get into our global and integrated. So this is where we start to go back into, going from a quad extension to a partial squat and working more holistically. But we want to make sure we're monitoring compensation patterns or aberrant movement patterns here, when we go back into it. I've had a lot of times where I've gone from isolated to global and then had to revert right back to isolated. So make sure we're staying sequential on these. Once we establish global, then we want to look to add layers to it and start to, blend cardinal planes and apply tempos and add our perturbations and combination movements. But we have to be chronological in order to be successful. Functional versus non-functional. Again, this is another one that could be an entire seminar in itself, but I look at it like this. Everybody has muscular imbalances, and we do not inherently need to fix them. For some people, they are very much functional. The easy example I always use is, if you're a college strength coach, go ahead and try to, muscularly balance out your starting pitcher, and you're going to be out of a job pretty quickly. So you have to have some discretion here and again, apply some logic. But there are also equally people who have non-functional asymmetries, right, where we're seeing, a 12 millimeter difference in left and right hip height. That is not a functional asymmetry, and that is something that needs to be addressed. And I know that this is another one that's a hot topic in debates in our community, but I've cleaned up a lot of back pain. I've cleaned up a lot of hip pain and other things just by getting, the pelvis to balance out and kind of reset that neutral. But this is also a big part of my application for core training is, getting the rib cage to sit right, getting the hips to sit right, and a lot of the times that'll clean up, some asymmetries or some ugly patterns. Compensatory patterns, another one can be tricky. A big misnomer for my realm is, that protective tension. And again, sometimes these things are needed. These athletes need these protective tensions. So it's not always something to address, but we need to be mindful of when we do and should address them. So wrapping it all up here, look at that, I'm right at an hour mark. Some general guidelines here. Shoulders, we want to make sure that we are independently strengthening the area. Oscillatory perturbation work has been great for shoulders for me. Restoring scapular range of motion, and then from there, scapular and scapulohumeral rhythm. Improving inner back strength to get the scaps to kind of sit where they need to, and restoring humeral external rotation, to kind of fully elucidate the cuff. For avoidances, we want to think overhead flexion beyond tolerance, deep ranges of extension, and anything that's contributing to a compensatory pattern. Spine, core strength is going to be a big one. Anterior core strength, multiplanar capacity. Whenever I think about the spine, I think about the tensegrity of the spine. So we're almost inherently going to be thinking multiplanar, multimodal. Hamstring strength, extensibility, breathing mechanics all play a factor. Things that we want to avoid: compressive loading, excessive flexion or extension. Know their intolerances on this. That can also be a rotational intolerance. Prone position, which is case specific. So disc degeneration, herniation, bulging. A lot of the times, putting them in a plank or a push-up can be a no-go. Heavy prolonged isometric holding. This is something that our disc population wants to be aware of as well. When we have intra-abdominal pressure building against a disc that isn't healthy, a lot of the times that can be a recipe for disaster. For hips, we're thinking single leg movements, improving glute strength, quad ham balance. Certainly don't forget about your adductors, but a big one here is moving in the frontal plane. Most people are very, very strong in the sagittal plane and very, very weak in the frontal plane, and that's, again, can be a recipe for disaster. Monitoring the ranges of hip flexion, contributing to bad or faulty patterns like a lateral shift in a squat or a unilateral hip hike, and anything inducing pain with the hips. Knees, again, we see single leg work, appropriate balance of ham quad, strengthening quads, strengthening the lateral glute muscles, and eccentrically strengthening hamstrings. For avoidances here, we're thinking flexion angles that induce pain. So for ACL, anything below 40 degrees, so short ranges of flexion. For meniscus or cartilage, anything beyond 90. Repetitive high forces is another one where, something that seems innocuous like jogging can actually be damning for knees. So make sure we're being mindful of that. And then deeper angles of dorsiflexion, especially under velocity, can be troubling for the knees. Ankles and feet, try to do as much as you can out of shoes. Obviously nothing with force impact. Soft tissue work on plantar and calf. Isometric foot strength. So we're thinking about, that bridge setup or like a floating heel setup. increasing controlled dorsiflexion, and then for our avoidances, Achilles ruptures especially, just be very mindful of load and velocity. Movements requiring big toe extension, and when you have somebody with plantar, my goodness, do not irritate plantar fasciitis. That will shut you down for a while. And then kind of tying it all together here, chronic and global. So this may not be anything specific, no specific diagnosis. Could just be fat and out of shape, just don't move well. But variation is really beneficial for a lot of this population, just because I think that they've really been relegated to either the same repetitive movements over and over again, which have started to induce some chronic global pain. But get them moving in multiple directions. Anything that helps subjective pain. There's nothing wrong at all with the placebo effect. If something helps somebody, let it rip, man. As long as it's not doing any residual harm elsewhere. If you don't think acupuncture means shit, but they get an effect from it, then let them go do acupuncture once a week. It's not that big of a deal. Things that reduce the intimidation factor of training is also one to consider. Give them things that they can be successful with. Sometimes people who have chronic and global pain have a significant intimidation about the gym, and they almost have this anticipatory response where they're assuming they're going to be in pain doing anything. So give them things that they can succeed with. And then obviously we want to stay off anything that induces pain or validates fear or intimidation, which will demote their self-confidence. So to the best of our ability, we never want to set anybody up for failure. Takeaway points here. Again, the overall point really being to not focus on the problem, but find the solution. I think with athletes who are injured, they're just inundated over and over and over again with what's wrong with them, what's broken, how long this recovery is going to be. You're not going to be able to do this. You're not going to be able to do that. Be that beacon of light that shows them what they can do, and kind of show them that there are things that they can work towards. And if we're working with high level athletes, it may not be the same grandiose type goals that they're used to working towards, but give them that same type of setup where instead of chasing a 400-pound bench press, maybe now we're chasing full restoration of overhead flexion. But in their mind, that's where they're at, and that's what's important to them. So it's very much a trial and error process. You got to be confident and be able to take some calculated risks to help get them where they need to be. But it all boils down to micro progressions and constant goal setting. Restorative strength is rehab plus performance training. We're finding the weak links without compromising the strengths. Consider all the factors that are needed here. We talked about, aerobic base, cardiac health, external modalities, working in tandem with other professionals, athletic trainers, physical therapists, there are a lot of different things at play here. And you got to be sure to understand that yourself and, just find what's needed. Wellness is essential. It really just, this is something that I'm just seeing more and more importance in as I go along. But, considering the aerobic base, multiple stressors all go to the same pool. So if we have marital stress, work stress, school stress, physical stress, emotional stress, those are all dumped into the same reserves. So when we get them into the gym, if they're coming in looking like shit because they already have everything else in the world bearing down on them, don't double down on that. Lacking good health is going to significantly perturb your rehab timeline, irrespective of who you are or what you do. Again, everything starts with the assessment. Let them show you what they need. Use a wide spectrum and modify what's needed. Scrap what doesn't fit. It's okay to think out of the box, and it's okay to try some different things. Just be transparent with your athletes, and again, make sure your risks are calculated. That about does it. I really appreciate you guys taking the time to tune into this, and again, hopefully you got something out of it. And for all of my other coaches who are still struggling, being out of work with the COVID event going on, hang in there. Hopefully we'll be having a turn for the better here in the next few weeks. But as always, if there's anything that we can do, or if anybody's looking to talk shop or jump on a Zoom call or anything, I'm always available for that, and all my contact stuff is over here. So thank you guys. Hopefully that was helpful, and hopefully I'll have another one of these here in the next week or two.